In this second of two films with Dr Wes Ely, Dr Asad Khan and I ask him about how he's treating long COVID patients at the moment, what his wish list would be for treatment trials, and the complex relationship of long COVID with MECFs. Hope you find it interesting.
I just wondered, outside the study, which we're looking forward to, how are you treating long COVID patients at the moment?
Eric Topol just published in his Ground Truth last week. He said, so now I'm going to turn to long COVID treatments. Below, you'll see the box of approved therapies. And he had a white box and it was empty. And so there are no approved therapies. What we know, of course, and we hope to get to that point, but we're going to have to use science to get there. I think each person represents a unique circumstance. And I try and find out, who are you? What matters to you? Which aspect of your long COVID is ruining your life the most? Is it a neck up set of cognitive issues? Is it a neck down set of problems that are disabling you? And then we work with our long COVID clinic, our post ICU clinic. We have physicians, we have psychologists, we have social workers, and all of us get together and we try to create individual treatment plans. And this could involve a lot of pacing, both cognitive and physical pacing. And then individualized care for things like cardiovascular meds for POTS. Some patients have found if they are ICU survivors and their problem is more PICS related than it is long COVID, they found some sort of cognitive rehabilitation helpful. On the other hand, some long COVID patients find that taxes them and gives them too much PEM, post-exertional malaise, cognitively, so we avoid that like the plague. And one of the practical things that we do in terms of pacing is we say, either think about how much you think you want to do today and cut that in half, or think about how much rest you need and double that. So those are two practical tips that patients find very useful. And beyond that, we're doing a lot of individualized care. Some of our patients have gotten things like plasmapheresis, some of them have gotten HBO, some of them get antiplatelet therapies, but none of these are proven therapies, but in some patients, they find usefulness from these different various and sundry treatments.
Apart from the trial that you're trying to get off the ground, what do you think are other interesting avenues for future treatments? So let's say that you were given the genie in the bottle who gave you a wish and said, okay, you can randomly spawn another 3 trials for other things. What avenues and what kind of things would you like to look at? And do you think that to some degree, there might be a case for one type of patient's going to need this kind of treatment, another kind of patients are going to, so some might need some kind of autoimmunity drug, another group of patients might need something to help metabolic function, another group might need something else. I wondered what your thoughts were on that.
Yeah, absolutely. I think that when we start looking at each patient, and we need to do that scientifically and measure different biomarkers, we will end up seeing that there are different profiles of patients suffering from long COVID. Some of them have tremendous ongoing endothelial damage with platelet activation and microclots. Let's put that up as one pattern. Let's take another patient who has ongoing immunological disorders, and really it's about an activated immune system and not so much the clotting. Then let's take another patient who has, for example, ongoing dysautonomia, and they are having too much problems with POTS disease, and then a fourth person where we detect active viral replication. So you can see how some of these patients might benefit more from antiplatelet therapy, other one more immune regulators and immunomodulation. I don't like to say immune suppression, I say immune modulation, because some people, by the way, for baricitinib are on that drug for years with rheumatoid arthritis and lupus, and they tolerate that well, but we're going to monitor the safety carefully. The dysautonomia, that patient might be best served by cardiovascular drugs that control heart rate and that sort of thing, and blood pressure. And then people with active viral replication might need the Paxlovid. And then are there combos? So combination therapies that need to occur. So I think those represent some practical examples for you of what I think needs to be studied very actively. And I will say one more thing, because it has to be happening in some of the listeners' minds right now, is timing. Like, hurry up, right? And there's been a lot of negative press right now about Recover Network. I am not myself part of the Recover Network. I am taking this reverse LC, RVLC study to a different section of the NIH. And that might make us more nimble and more rapidly able to get the trial underway and completed. But I cannot speak for, and I don't want to talk negatively about my colleagues doing different sorts of trials, but all of us are aware that people need help yesterday. And if we're really going to be their servants, we need to get rid of the regulatory mumbo jumbo that is clogging up these pipes, open the pipes up and get the water flowing so we can get answers.
100%.
Yeah, and thank you for that plea for pragmatism. I mean, it's needed both in the arena of research, but also in the arena of therapeutics. And what you're doing, in the absence of recognized treatments, and just going, hey, this is the patient in front of me. What are their needs? And we seem to have lost that ability to think and offer trials of treatments. Sorry, rant over, but that's a big bugbear of mine, where we become slaves to guidelines and protocols. But following on from this, we still live in a climate where complex chronic disease is often neglected and it's psychologized, and as a result, patients suffer. What will it take for medicine to do better?
Yeah, I'm so glad you're asking this, Asad. I am a medical insider. I was raised in traditional academic Western medicine. I went to medical school. After college, I went to 4 years of medical school. Then I did a 3-year residency in internal medicine. Then I did a 3-year fellowship in pulmonary and critical care. Then I did a chief resident year. Then I did a lung transplant fellowship. So it went on forever. And it's about knowing the science, citing chapter and verse each study, knowing these authors, reading the method sections. We can get too regimented in our approach to where we don't see the person sitting in front of us. And I think that is a mistake. And so when diseases like MECFS come along over the last 20 years of people poo-pooing that disease, and a clinical trial series is done, multiple trials done, and all of them negative, medical insiders like myself will deny the disease as a disease. And people are taught in medical school, these aren't real diseases, there are no treatments, and the patients don't fit into a box. And therefore we get closed-minded and think that patients are psychologizing their symptoms and need to have mental health or psychological therapy. I can talk about this because I am guilty of this. I am not pointing fingers at my colleagues. I'm saying that I thought like this. Long COVID has woken me up to the error of my ways. I sit here, talk to you today as hopefully I'm in reform. And I think that I was in error. And the way I want to live my life as a physician going forward is different. I want to change. I want to change medicine to say, let's pay attention to patients who do not have a voice. And the most important person that I need to listen to is those who are least heard. For years, I think as an ICU doctor, I was willing to dive into chaos, but I did not provide lifting and healing, because I cannot lift and heal you if I don't hear you and pay attention to you. And with a compassionate statement, say, you know what, Asad, Jez, I don't have an answer for you, but I can promise you this. I will not leave you. I will not abandon you. And I will set up a community where you will be heard and where we can scream and yell and pay attention to one another, and where I will accompany you as we go forward in the months and years to find you some answers.
Just talking about MECFS, there has been quite a lot of research done on MECFS, but not all of it sort of reached, permeated through into the big journals and made the waves. But there is quite a lot of interesting stuff in there. I was wondering if, since your reform, you've had a chance to go back and look at some of it with a view to what might lend some clues to what's going on in long COVID, because we are starting to find a lot of these links going on between the two in terms of pathology that they share.
Absolutely. And I've gone back into that literature in depth and read so much about MECFS, because I think in MECFS, we can understand long COVID better and vice versa. In fact, I've become very close friends with some of the leaders in the MECFS world. And right now I'm on a committee with the National Academy of Medicine to redefine long COVID. And I don't mean trash previous definitions, they were wrong. I mean, take the CDC, the World Health Organization, multiple different definitions, and see what have we learned so that we can advance the definition, the working definition, and advance science and clinical services. Anyway, on that committee, we have MECFS patients and we have MECFS scientists. So I think there's so much to learn from MECFS. And those theories that I said a moment ago about dysautonomia and activated immune systems, those are from the literature of the MECFS community. I'll go on to say one more thing, which is that one of the books I read by a famous New York Times reporter who got MECFS and might now have long COVID was a beautiful example of how he was just denied over and over and over again by the medical community, to a point where he went into these deep places in his mind and his heart, trying to dig his way back out and find his own personal identity amidst his new normal. And the MECFS community has been suffering in that way for years, and I'm here to learn. I'm the student.
I mean, that was so powerful. I think we both know who you're talking about, by the way, without revealing the name. But yeah, I mean, it's really frustrating when we see experiments being repeated where we already know the answers. So the MECFS literature has a lot to yield, and we shouldn't forget that at the end of the day, this is a virus as well. You know, it might be a new virus, but it is still a virus. And in a lot of people, it will cause MECFS, and indeed it is doing so. I just wondered if you had any parting words for people with long COVID.
Yeah, my thoughts about those of you listening are, first, I'm sorry for your suffering. I don't know what you're going through. I can't pretend to understand it. And yet each week I spend time inbox email every week, every day, and in our support groups and people contacting me, and I try to call each person back on their cell phone. Understand, I've got a couple of people I'm going to call as soon as we get off here that have written to me and tell me about their daughter, their husband, or themselves, and learn from you. My first thought is, don't give up hope. Never give up hope. There is always a place in the future for recovery and healing. And it may not be that you are able to get back exactly where you were before, but there is a new normal and a place that we can get to, all of us, you and I can get to. I want to change as a person, and I do not want to live the way I did yesterday. And I hope that you can find a place through your suffering to know that you're teaching people like me. If nothing else, you're teaching doctors like me to do a better job as a healer. And I appreciate you more than you know for all that you've taught me over the past year or two. And I look forward to the next 20 years of service if I can stick around. And I want us all to do a better job for you to make your life have less suffering, more hope, and a better future.
Thank you so much for your time today, Wes. Thank you for all of your work, and I wish you the best with the trial. It's really exciting, and I hope that the wheels can start turning on that soon. Hope you found that as interesting as we did. Next on the channel, Dr. Asad Khan and I will be talking to superstar virologist Professor Akiko Iwasaki, so stay tuned for that. And finally, if you're not aware of the Long COVID Handbook and you happen to want a singular resource that brings together everything we know about the condition into one concise and accessible place, well, perhaps you should be. Links in the description. And have a look at the Amazon reviews to see what other long haulers think about it. And even more finally, a quick shout out for my second channel, Flip the Script, where I break down from an insider's perspective why big films and TV shows work or don't. Again, links in the description. And properly, finally, if you're wondering, I probably will get a haircut before you see me again. Look after yourselves. Until next time.